Hello, and welcome to the Utah Criminal Justice Center's Virtual Skills Series. This is part 3 of a 3-part series addressing the risk, need, and responsivity model. Today we will be talking about responsivity. Since we'll be recording this not in a live chat, hello, and welcome to the Utah Criminal Justice Center's virtual skills series on the risk, need, and responsivity model. Today is the third of 3 modules we've done, and we'll be focusing on responsivity today. My name is Christian Starber, and I am the Associate Director of the Utah Criminal Justice Center. This is more information about the Utah Criminal Justice Center. We are a research organization based at the University of Utah in the College of Social Work. And we'll be talking today about responsivity, which is one component of the Correctional Program Assessment Checklist, which some agencies in the state are assessed on. Before we start, I just want to remind us all of the definition of recidivism that we are using when talking about justice-involved clients. Recidivism is measured by criminal acts that result in rearrest, reconviction, or return to prison with or without a new sentence during a 3-year period following the individual's release. You also obviously may be addressing other problems that your clients have, but the research and practices we're talking about today are specific to reducing recidivism. We have 3 learning objectives today, which will be to talk about the 2 types of responsivity, specific responsivity and general responsivity, and the role of responsivity in case planning. A quick review of the 2 previous modules in this series, one of which talked about the risk principle, and the risk principle is really telling you who to target, right, to focus treatment resources on those individuals who have been assessed as being moderate or high risk of recidivism. The risk principle also tells you how much treatment to give, right? So higher risk individuals should receive more hours of treatment. The need principle will tell you what to target in terms of treatment targets. So for example, substance abuse would be a treatment target. It also tells you how to prioritize treatment targets. So you're thinking about how the needs, which are most acute, and how they work together to drive offending behavior. So a quiz today, which is to think about which of the following are appropriate treatment targets for reducing recidivism. So the ones that would be treatment targets would be client focuses on the fact that no one was hurt by criminal behavior, which would be an antisocial attitude, minimizing the behavior. Client is combative when confronting other clients in group, which would be an indicator of some antisocial personality pattern where the person is behaving with others in aggressive or antisocial ways. Client does not see the value of having a job would also be a criminogenic need in the area of problems with employment and education, and also potentially with antisocial attitudes in terms of thinking about what are appropriate and inappropriate ways to make a living. The other examples here, client does not participate in group interventions, would be an example of motivation, so not a primary treatment target. Also, client endorses symptoms of depression, which is a mental health, obviously, issue, would not be a primary treatment target for reducing recidivism. Those are examples of responsivity, which we'll be talking about more today. The final one, client's family is not supportive of treatment, could be a primary treatment target if the dynamics in the family are driving recidivism in terms of the family endorsing a lot of antisocial attitudes, values themselves, engaging in criminal behavior. It may also be a responsivity target if the client is dependent on the family, for example, to get transportation to treatment, and the family is unwilling to provide that. So when you talk about the responsivity principle broadly, you are talking about how to promote client engagement and learning most efficiently and effectively, right? So you know who you're targeting, you know what you're targeting, and this is essentially how to provide those interventions in a way that is most likely to be effective. So there are two forms, specific and general. Specific responsivity is really knowing and attending to the client attributes that limit and/or facilitate the client's learning style. The second component of specific responsivity is knowing and attending to therapist and intervention characteristics that promote client engagement and learning. So some examples of that, client characteristics that might impact learning would be, for example, motivation. Again, going back to our previous slide, talking about primary treatment targets, motivation is not a primary treatment target. However, obviously, if a client is unmotivated in treatment, they are unlikely to benefit from treatment. So what responsivity would say is you should address concerns with motivation and then start providing the treatment intended to reduce recidivism once the client's motivation has changed. Cognitive ability would be examples of, for example, interventions that are manualized that require a certain reading level. If a client doesn't have that reading capability, they obviously are not going to be able to participate in the intervention and may need a different intervention or some assistance in moving through the modules. Gender, there is some research that suggests that justice-involved women have a lot more problems in the areas, for example, of trauma and mental health. So it may be that you're having to provide trauma-informed interventions and or respond to concerns about PTSD and other trauma-related symptoms before someone is able to participate in treatment. Culture, most simply, is in the form of having adequate access to interpreters, translators, translated documents. I know I did a program evaluation at one point where two of the individuals in the treatment program spoke Vietnamese and very little English. None of the treatment providers spoke Vietnamese at all. So presumably those individuals were not benefiting much from that treatment intervention. That is often a resource issue, right? That programs don't have the capacity, but something to think about in terms of providing services to folks with different languages. Mental health symptoms, again, we talked about depression in the earlier slide. Obviously, depression, mental illness, psychosis, all of those may be important and may impact the client's ability to engage in treatment and must be addressed and probably have to be addressed before the client engages in treatment. The RNR model, though, would say that those mental health symptoms, if you resolve symptoms in mental health, you are not going to reduce recidivism because that's not a primary driver of recidivism. Stability falls into the area of kind of clients' basic needs. So clients who are struggling with food, transportation, housing security, life crises in general, right? Probably need assistance resolving those before they're able to participate in treatment. Many programs address that through use of case managers that are checking in to make sure clients' kind of basic needs are being met. And then you also want to think about client strengths when building a treatment plan. So responsivity would say you really want to think about areas of interest, areas of accomplishment. If someone is struggling in terms of education, but really, really values that, finds it really important, is really motivated, that you would maybe address problems in education up front to help motivate that person to engage in treatment further. Therapist characteristics that may affect the efficacy of treatment. These are often called core correctional practices. Those of you who are therapists, I think, will recognize them also as the elements of building a therapeutic alliance. But essentially, you want therapists who work with justice-involved persons to be very collaborative. Because justice-involved clients are often mandated to treatment, you still want to create a space where that person feels involved and engaged in the process of developing a treatment plan. So that may come in the form, again, of thinking about strengths, of adjusting treatment targets to kind of build on what motivates the client. You want someone who is warm and caring, empathetic, respectful, right? So all of those, seeing the person as a human, as a client, and not as primarily an offender. Genuine, research has shown very important, right? That the therapist, the clinician, that the program staff believes that the person is capable of change, that they can authentically engage that person even when perhaps they're behaving in difficult ways that they believe that for the possibility of change. And again, committed to helping client goes along with that. And then the final one is really that you want individuals who can be firm but fair, individuals who can kind of hold clients accountable for behaviors, attitudes, interactions, but can also move past that and again come back to the belief that the client is capable of change. You will see that some traits can be both need and responsivity. So in the area, for example, of antisocial personality pattern, someone who scores high in risk in this area, treatment targets may include callousness towards others, impulsivity in terms of controlling behavior, aggression, manipulation, and restlessness. Those are also going to be possible responsivity issues, right? Because someone who is feeling callous, impulsive, aggressive, manipulative, right, that probably speaks to their engagement in treatment, but it also speaks to the ability of the clinician to develop a therapeutic relationship with that person, right? Because that person is going to be harder to build that relationship with. Those individuals can also create a lot of problems in groups and have negative impacts on other group members. So it may be that while you're working on these treatment targets, your responsivity way of addressing responsivity would be to have that person in one-on-one sessions and not in groups with others. And then again, thinking about how you are building that therapeutic relationship while working through these treatment targets and who you assign a client like this to, right? So they're going to be therapists, clinicians, and staff who are more comfortable with this personality type than others. So thinking again with your clinicians, where is their comfort? This can also obviously be addressed in group supervision, right? Talking about strategies for working with this client and checking in on how therapists and program staff are reacting to and responding to this client. So before we talk about general responsivity, I want to talk about the general theoretical framework of the RNR model, which essentially posits that offending activity develops through social contact with those who are not opposed to antisocial behavior. Offending activity is then reinforced through operant and classical conditioning so that rewards associated with this behavior contribute to the continuation of the offending behavior. So this is really at heart a behavioral model. So with that, the most effective interventions for reducing future recidivism are cognitive and behavioral interventions. The research on responsivity shows you here, you can see on the side of the chart, you're looking at reductions in recidivism for non-behavioral programs. The reduction in recidivism is about 0.07%. So clients who participate in non-behavioral interventions, their ultimate reduction in recidivism is about 0.07% compared to what it would be expected to be. For those who participate in behavioral interventions, that's about 30%, right? So those are much bigger reductions in recidivism for behavioral versus non-behavioral interventions. So when you're thinking about providing interventions to reduce a behavior, you want to think about how a behavior is learned, right? And so that is typically through observation and modeling, and then experience through interactions, rewards, costs, and additive and subtractive events. A way to think about this is thinking about, again, how, for example, a young child learns not to run across the street without looking first, right? So the child might be told not to do that. That would be an example perhaps of modeling, that an adult is modeling for the child. Every time we get to a crosswalk, we stop, we look both ways before we cross. Also telling the child not to cross, but also there is an experience or an interaction there, right? So the child may start to cross the street without looking and be scared by a car that comes by and comes close to hitting them. The child might see someone else get hit, right? The child, so that there is some sort of interaction or experience that happens that reinforces for the child that she should not run across the street. Another component to this, though, is that it may be that the parent is modeling one behavior and an older sibling is modeling a different behavior, and the child is kind of more interested in what the older sibling is saying, doing, and modeling than the parent. So that would, again, be an example. It's probably too strong to say of an antisocial peer, right? But part of the strength of modeling is how important the person who is modeling the behavior is to the person who is learning the behavior. Again, that speaks to that therapeutic alliance. People who have stronger relationships with clients are going to have more impact in terms of teaching new behaviors. And then again, the second part of this that's really important is this experience of something, right? So if a child starts to run across the street and the parent yells at the child, right, that might be a negative experience that reinforces you shouldn't run across the street without looking. So when you're thinking about recidivism, the potential for reduced criminal behavior resides not so much in reduced motivation for crime, but in the potential for altering the reward cost contingencies for crime and non-criminal alternatives. So essentially what that means is someone who is at high risk of recidivism has had a lot of positive experiences as the result of committing crime. So that might be the social appraisal of others, right? Their peers think it's cool. It might be that that's how they make a ton of money, and that seems like an easier way or to make money than working, or a way to make more money. There is also the issue that for most crimes individuals commit, you're not necessarily caught. And an example of this would be speeding, right? So I'm someone who tends not to break most laws, but I do speed a lot. And the reasons that I speed include both I never get caught, or I rarely get caught. So I don't have an experience of a cost for the most time. For the most part, I get away with speeding. It may also be that there are rewards for me in speeding, right? So it may be that I get where I want to go faster. It may be that it's fun for me to speed. So if you want to change the calculus of that, to change my behavior, one way to do that would be to increase the cost, right? So to increase the chances that I get caught. So for example, if I do get a ticket for the next month or 2 months or 6 months, right, I'm less likely to speed because I've had a consequence. It may also be that the rewards are changed, right? So I'm speeding because I would get where I want to go faster, but once I get caught, that's slowing me down. So I'm no longer having that reward, and or I see an accident, which suggests to me like maybe getting there faster isn't worth the potential downside. If I'm doing it because it's fun, you would maybe, this is a silly example, but if I took some sort of drug where if I went over 55 miles an hour, I got really dizzy, that would take the fun part away. That's something that we do with methadone, right? In terms of alcohol use, that you take away the reward in some fashion. So when you're thinking about recidivism, what you really want to do is kind of increase the cost of crime, reduce the rewards of crime, and reduce the cost of other non-criminal alternatives, and increase the rewards for those alternatives. So when you're thinking about rewards and costs, right, those can come from a couple of different sources, right? So the most basic one of those is non-mediated, right? So that again would be an example of methadone, that if you give someone methadone, you are taking away the reward that they experience from consuming alcohol, right? So these non-mediated ones tend to be the most effective teachers, particularly for non-motivated clients. Again, touching a hot stove is a great example of that, right? The quickest way to learn how not to touch a hot stove is not to be told not to touch it, right? But to see someone else touch it and or touch it yourself and experience that, right? So you immediately have a negative experience, a cost associated with that. You can also have those rewards and costs be personal. So when you think about that, you're really talking there about someone's antisocial or pro-social values, thoughts and attitudes and cognitions, right? So if I see myself as someone who does not commit crimes or doesn't want to be perceived as someone who commit crimes, right? That in and of itself probably prohibits me from committing a crime. So for example, if I go home tonight and I see that my neighbor has left their car unlocked and there's a computer sitting on the front seat, right? My response to that in part would be to either lock the door and take the computer to my neighbor, right? And some part of that is because that's who I see myself as, right? So that would be an example of kind of a personal reward for me, is feeling like I am a person who behaves that way, right? But it also would feel like a negative cost to me to take that computer, because that's against who I see myself as. There's also an interpersonal component to that though, right? So obviously if I value my neighbor, if I have some sort of interpersonal relationship, that also might introduce rewards and costs that would matter to me and change the calculus of that behavior for me. So when you're talking about general responsivity and the core correctional practices, effective interventions really are based on appropriate modeling and reinforcement, right? So that's saying when you teach someone a new behavior, you first of all model that behavior. You model what it looks like to resolve conflict in a pro-social way. You model what it looks like to kind of problem solve to identify impulsivity and problem solve in a new way, right? So that might be the therapist themselves actually creating a scenario and modeling that. That also can be role playing, right? You would model a behavior of declining peer pressure. And then you want to use positive reinforcement and effective disapproval techniques. So effective disapproval techniques are those ones that are non-shaming, that provide feedback, and that redirect and focus more on the positive behavior and not on the negative behavior. So you don't want to spend a ton of time saying that's not what you should do. You want to spend time on what you want someone to do. That also might be that in group, if you're seeing someone be disruptive, you are disapproving of that in a way that is bringing them back into the group, not driving them out of the group, right? So you might draw attention to them. And then you also, again, really want to demonstrate and reinforce alternatives to antisocial thoughts and behaviors. So again, modeling the behavior, practicing the behavior, and providing behavioral supports. For general responsivity, you also, again, want to do a lot of skill building and problem solving. That occurs in structured learning activities. So that's not process oriented. It's not thinking as much about how the client feels generally, but it's thinking specifically through, okay, let's talk about this situation. What got you into this situation? What activities are you worried about in this situation? What are alternative strategies for getting out of this situation? Again, you want to practice the new behaviors, and you want there to be feedback from the clinician, feedback from the group, right? That again is really focusing on the positive behavior you want to see, not focusing on the negative behaviors. New skills should really be specific to clients' criminogenic needs. So often in, for example, residential juvenile settings, you will see a lot of focus put on kind of compliance with kind of household rules, having a clean room and making your bed. Those are fine in terms of managing a residential space, but it's not necessarily clear that learning how to make a bed has anything to do with clients' right recidivism. So you really want to think about what are the skills that this client needs to behave differently when the opportunity to commit crime occurs. And then again, you want to think about cognitive restructuring. Going back to the previous slide, right? You want to think about the client's values, the client's feelings, thoughts about work, about who they are, about what are acceptable ways to make money. When you're thinking about case planning and responsivity, you really, again, at the outset want to identify and address barriers and strengths for treatment engagement. So these things can change over time. Someone might show up to your setting feeling depressed, but having a stable housing situation. And then in 3 months, the depression has resolved or somewhat resolved, but they are facing homelessness. So you really want to do ongoing assessment and monitoring to see what things are impacting the client's ability to engage in treatment. And you want to make sure that you have a response for those items you're assessing for. So we not infrequently see in programs that they're assessing for responsivity, but then nothing happens with it. So you do a motivation assessment, but there's no motivational interviewing group. You want to match clients, clinicians, and interventions, right, in terms of relative characteristics. So that may be gender, culture, again, so that you would have staff who speak Spanish, for example, running groups for Spanish-speaking clients or clients who speak primarily Spanish. It may be personality. We talked about this earlier for clients who are really challenging in terms of anti-personality patterns, antisocial personality patterns. You may really, with those clients, think about what clinicians work best with that type of client. Training, obviously, if you're having folks running substance abuse groups, they should have some sort of training, licensing, certification in substance abuse. And then again, cognitive ability, thinking about is the client actually able to engage in the intervention? Can they read the materials if that's required? You want to identify individualized, meaningful consequences. So again, those are those rewards and costs. And because in a therapeutic group, you're often talking about things such as verbal praise or drawing negative attention to someone, thinking about a client, for example, in a group, I never want attention drawn specifically to me. So it wouldn't be a reward to me for someone to, in front of the group, say to me, hey, you did a great job. For me, it would be much more valuable to say that to me one-on-one, pulling me aside. It would feel almost the opposite if someone responded to my participation in group by making a big deal of that. That's not true for all individuals. So thinking about what individual clients experience as a reward or a cost. And then interventions targeting criminogenic needs should be skill-based. They should be focused on problem solving, again, very present focus. So we're not thinking so much about how did the person develop problems around impulsivity, but how, given that the person tends to be impulsive, can they identify that and kind of employ problem solving skills to behave differently. You want to incorporate consequences to encourage or discourage behavior and address thinking patterns, again, that support antisocial behavior. So again, in the RNR model, these cognitive and behavioral interventions are important because you are trying to change a behavior, and that being recidivism. That is the end of today's session. So you can email, let me go back to the beginning, Jessica C. Wright, if you would like to take CEU, and her email is right here, jessicacwright@utah.edu. That is it for today. Also, please feel free to reach out to UCJC with questions. Our contact information is in the slides. Thank you so much.